Good morning, dear students. This lesson is about a clinical approach to a patient having axial spondyloarthritis. Of course, in its severe form, it will be called ankylosing spondylitis. For you as students, we will concentrate on the case as being ankylosing spondylitis. Before we proceed with our clinical presentation, I just want us to revise the definition of spondyloarthritis. What is spondyloarthritis? Of course, spondyloarthritis comes from three Greek words. Spondylo means back, arthritis means joints, and itis is inflammation. So spondyloarthritis is inflammation of the axial spine, put simply. It's not one disease, it's a group of diseases. Today we will just be discussing ankylosing spondylitis. But what brings these diseases together is that there is chronic inflammation in multiple sites. The most important musculoskeletal sites are the synovium, synovitis, enthesitis, and the extra-articular targets. Also, these group of diseases have a strong predilection for the sacroiliac spines. That is why we get sacroiliitis, and that will be the cause of the low back pain that we will be hearing about in a couple of minutes. Often there is association with HLA-B27. These patients are negative for rheumatoid factor, and that is why we had the old name seronegative, and there is a family tendency. So these are the group of diseases that we have. The prototype, what you should know very well, is the ankylosing spondylitis, and the other entities is what you've taken in the lectures. So the clinical subsets that you should know very well include ankylosing spondylitis. At the hallmark is the sacroiliitis. Of course, in rheumatology, we have this classical approach. All of our approaches start with a couple of questions. We should ask always about the duration. Is it acute in onset or chronic in onset? What are the number of joints involved? Is it monoarthritis, a single joint, oligoarthritis, 2 to 4, or more than 4? Is it polyarthritis? We should always ask, is it symmetrical or asymmetrical? Is the pattern of joint involvement additive or migratory? Because if it's migratory, we'll think of causes of migratory arthritis, such as rheumatic fever, for example, or other infectious diseases which can be migratory. Also, we have to delineate the joints. Is it the axial joints or the peripheral joints? Very important, is it inflammatory or non-inflammatory? Are there constitutional manifestations? And very important, the extra-articular manifestations. When my patient dies of a rheumatic disease, he won't die because his joints are affected. He'll die because of the extra-articular manifestations and the comorbidities. Very important symptom in rheumatology is to ask about the morning stiffness. Morning stiffness immediately gives you the indicator that you are dealing with an inflammatory disease. The longer the duration of morning stiffness, the more severe is the inflammatory disease. And very important, as we'll see in a minute, is we have to ask, is this inflammation getting better with pain, with movement or not? We'll refer this to the patient. So, is it inflammatory or non-inflammatory? If it's inflammatory, we will have in the history stiffness in the morning, early morning stiffness, nocturnal pain, stiffness that gets better and pain that gets better on movement and gets worse after periods of inactivity. So this is the pattern it's involved. It's very important. Let's move on to our patient. As I said, the most important thing is to take a very good history and to ask about the history. I think I want to stop here and go to our patient. So let's go to our patient. We have a male patient here named عم فاروق. صباح الخير عم فاروق. بعد إذن حضرتك أنا بس هسألك شوية أسئلة وهكشف عليك ومش هطول معك. أوكي. عم فاروق عندك كم سنة؟
أنا عندي
60 سنة. وعندك كم أولاد؟
عندي
4. متجوز وعندك 4 أولاد.
أيوه.
كنت بتشتغل إيه؟
أنا كنت بشتغل في السفن التجارية.
تمام. ما زال بتشتغل ولا طلعت؟ بقالك قد إيه سايب شغلك؟
لا بقالي حوالي 15 سنة من السن ال 40 هو
ابتديت work disability starts early. أوكي. الشكوى ابتدت من امتى عم فاروق؟
هي ابتدت عندي اول حاجه ابتدت من تحت من الهواء. بيجي لي وجع.
من كام سنه؟
حوالي من 18 سنه كده.
18 سنه. ساعتها كان عندك تقريبا
كان في حوالي
ثلاثينات 40 سنه.
كده
تمام. ابتدى بآلام في اسفل الظهر.
جاي من تحت كده بقيت اخد له مسكن كده وبقيت اشتغل، لقيت نفسي بزيد. رحت الدكاتره بره ما عرفوش يشخصوني بصراحه.
الالام دي فضلت معاك قد ايه يا عم فاروق؟
قعدت معايا حوالي سنه وجعاني.
وخد بس بتروح تاخد مسكنات تهدى تكمل تاني.
بعدين
الالام دي كان بتيجي اكتر بالليل ولا بالنهار؟
لا هو كان بيجي لما كنت بنام كان بيزيد عليا الوجع، اقوم اتحرك شويه كده.
يعني الحركه بتخلي الوجع بيبقى افضل.
بيقل. يعني
ممكن قرب الفجر كده تقوم تحس بألام.
أيوة
وتتحرك
شويه كده
الألم تتحسن.
اتحسن.
اول ما تقوم الصبح كان في
بتخشب كده باخد لي حوالي ساعه او ربع كده عبال ما يفك معايا الحال، يفك معايا ويمشي.
في بدايه التعب. حاليا لسه في التخشيبه دي؟
لسه في التخشيبه.
وبتقعد قد ايه؟
بتقعد لها حوالي بتاع ساعه كده.
ما زال الى الان. الى الان. الالام اللي في الاسفل الظهر دي طلعت لفوق.
لحد الرقبه ما بيش.
يعني الحاله كان بتتطور وتزيد.
بتزيد. وبعد كده
انت قعدت سنه من غير اي تشخيص. امتى جيت عشان تدور ولقيت؟
جيت هنا هم اللي عرفوا هنا في المستشفى هنا. هم اللي عرفوا عندي ايه.
ساعه ما جيت كان عندك الام في اسفل الظهر وكان في الام في اماكن تانية.
بالظبط.
فين تاني؟
كان بيجي لي في الرجل هنا من تحت الركبه كده بالانكل في وجع.
في الام في كعب الرجل؟
بالظبط.
في الام.
اقوم الصبح كده الاقي زي كأني ماشي
في الواحد ولا الاثنين؟ الاثنين. الرقبه فيها الام يا عم فاروق؟
فيها الام. لو عملت كده في الام. لو عملت كده ما اقدرش
برضه في الم.
في الم. بص تحت كده الالم يضرب لحد العضل.
عاوز اسال حضرتك في اي مشاكل التانية يعني في عينيك؟
ايوه بالليل كده عينيا كده بتدمع كده وتحمر وبتدمع تنزل دموع. بحس كده كأن فيها رمله كده، واحد ماشي كده ولقى في شويه رمله كده.
كشفت رمد قالوا لك يعني كان في التهابات في عينيك؟
كان
في حصل التهابات؟
حصل في التهابات.
في اي مشاكل في القولون؟
لا في الصدر بقى.
في الصدر
مجهود جامد. الاقي الصدر كده وجعني كده ارتاح شويه
مع المجهود. اما تيجي تطلع سلم مثلا.
بالظبط كده.
تمام. انت مش بتشرب سجاير طبعا؟
لا دلوقتي لا.
بطلت.
بشرب الاول بس دلوقتي.
تمام. في اي حد تاني في العيله عنده نفس المشكله؟
لا هم عندهم بس عندهم بروتيزم بس. يعني عندهم يعني سكر.
بس ما فيش اي حد. ما فيش اي طفح في جلدك؟
لا هو ما جاش الحمد لله. يعني
الحمد لله. تمام. ماشي يا عم. اخذت علاج. العلاج اتحسنت بالعلاج؟
يعني بتحسن بس مش هو التحسين.
تمام. دلوقتي يعني if we summarize the history of our patient, we have a male patient. He is 60 years of age. He's been complaining for about 20 years. The initial presenting symptom was chronic low back pain. Of course, when we get chronic low back pain in an individual in the range of 40 to 45, we immediately think of inflammatory low back pain. It's not the commonest cause of low back pain. Low back pain can be due to a million other causes. But if he has pain that has been lasting more than 3 months, so this is definitely more than 3 months, his age is, at the time of the complaints, was less than 45, immediately I have to think that this pain is inflammatory low back pain, and I have to have the differentiating factor between it and the non-inflammatory pain. For it to be inflammatory back pain, I need 4 important criteria that have to be present, and they are all present here in Amm Farouq's history. He said the pain lasted has been lasting for many years. That's more than 3 months definitely. It started when he was 45 years of age. It was associated with morning stiffness lasting about 1 hour in the early morning. It's associated with nocturnal pain, and he says the pain gets better when he starts moving around, and it gets worse after periods of inactivity, and particularly at night. So we have all the criteria here. I need 4 out of the 5. I've got all 5 criteria that my patient has got inflammatory chronic low back pain. In addition to that, Amr Farouk said that he also has heel pain. As we said in the slides, the heel pain is attributed to the enthesitis. Enthesis is a site of attachment of a tendon or a ligament to the bone. So there's heel pain as well. There is neck pain as well. And is also complaining of chest pain. So these people are quite miserable because they have pain in variable sites. Low back pain, chest pain, heel pain, and neck pain. And this is associated with morning stiffness. When I moved on to the extra-articular features, which is very important in our patient, important features to ask about in the review of your systems include the eye. Eye presentation, particularly anterior uveitis, may be the presenting feature. We also have to ask about respiratory complications. As we'll see, he can get respiratory complications due to many causes, pathology in the lung, or due to restrictive lung disease because of affection of the central joints. As we said, axial spondylitis involves the axial joints and the central joints, including the manubrious sternal and the costovertebral joints as well. So, from the history, we are almost 99% sure that our patient has got ankylosing spondylitis. But we will proceed as well in the investigation. So don't forget to review the systems, particularly the eye, the chest, the heart, because we can get complications such as aortitis. Also the GIT is very important as well. And of course, peripheral arthritis. If these people get affection of the joints, it will usually be large joints, girdle joints, shoulder and hip joints, maybe also the knee joints. It may also be asymmetrical. So if there is arthritis, it's usually large girdle joints and it's asymmetrical. Keep that in mind as well. So that is as far as the history is concerned. Family history is very important as well. And also we have to ask about skin affection, because we have the psoriatic arthritis, which may also present in this way as well. Okay, so that is as far as the history is concerned. Moving on to how we examine our patient. Of course, the first thing we have to do is to see the gait of our patient. We have to get the patient as uncovered as possible. معلش يا عم فاروق هشيل الفانيلا كمان بعد اذن حضرتك يعني. انا عايزاك تمشي. ممكن يمشي ازاي عشان ايه؟
امشي
من هنا لهناك؟
ممكن اجيب
ولا ايه اللي؟
شوف امشي كده الاول.
Okay. Okay. When the patient walks, we look at the gait cycle. We look at the asymmetry. We look at the turning. He's doing it very, very slowly. He's taking small steps. He's lost the usual stride that we have, and he is stooped forwards. So from the gait of our patient, we note that he has got a stooped gait. He's not antalgic. He's not in any severe pain. He hasn't got sciatica, but he has got small steps, stooped forward, and he is taking time to move. So the first thing we see is the gait of our patient. Then we have to inspect the back. The back is inspected in many ways. First of all, we inspect it from behind. What do we note from behind? We have to look at two things. We have to look at the curvatures. Here we've got cervical lordosis, the dorsal kyphosis, and then as we go down, we have complete obliteration. That's by inspection. I palpate it just by inspection. We see that there is the curvatures and there is asymmetry, and there's complete loss of the curvatures of the back. Also by inspection, we look at the symmetry of the shoulders. We look at the scapulae. معلش عم فاروق ممكن يجي في
الحته
لا عم فاروق دوس على الحيط عم فاروق. Okay, we look at the scapulae. Okay, we look at if there's any scar of previous operations. Many patients are subjected to unnecessary surgery. We also look at if there is any scoliosis. Some scoliosis is evident, and what is very evident is complete obliteration of the lumbar lordosis. So that's from the back. From the front of the patient, we look at the head and neck posture. As you see, there is stooping forward of the head and neck. And from the lateral side, so we look from the back, from the front, and from the lateral side as well. From the lateral side, we can also again see the irregularities in the spinal curvature as well. Okay, so that's by inspection. By palpation, we bring our finger, أنا هحس ظهرك معلش يا عم فاروق، همشي إيدي كده, and we look at all the spinal processes. We feel for any irregularities. Okay, complete obliteration of the lumbar lordosis. We look if there is any active muscle spasm in the paravertebral muscles. And we look as well at the sacral dimples, which are very evident here as well. Okay, right. قبل ما أعادك, we also look at the cervical. Okay, we can do that as well. If we go back, of course you've taken this previously, but for us to see the cervical range of motion, we all know in a normal individual we have chin to chest. بص جيب دانك لتحت على قد ما تقدر.
كده آخر حاجة.
He can't do it more than that. Usually we bring our chin to our chest. بص على السقف يا عم.
آخر حاجة.
He can't look up at the ceiling. He can't see the sun. When the sun comes out, he can't see it. بص على الحيطة. He can't have the rotation. So we've got flexion, extension, lateral rotation, and as well جيب ودنك لكتفك بس من غير ما ترفع كتفك لفوق. معلش أنا أسف. He can't. So we have got almost complete loss of all the cervical range of motion. The test that we have is to test for the range of cervical motion is known as the occiput to wall test. معلش عم أجيب. We get the patient to be barefoot, bring his heel against the walls, and we get our tape measure. And we measure, all of us, the occiput should touch the wall. Here we have a very significant occiput to wall test. If we measure from the occiput to the wall, it's very, very significant. It exceeds even 16 centimeters or more. Okay, so that's the positive. Also the occiput to wall test, sometimes we use it as a prognostic test. If our patient comes to us early and we give him treatment, he gets better, the occiput to wall distance gets better. So it can be used for prognosis. So that's the occiput to wall test. Okay. تعال هنا عم فاروق. طيب أنا عاوزاك يعني توطي على قد ما تقدر.
آخر حاجة.
Yeah. So we do lumbar flexion. آخر حاجة. It doesn't go any further. أعمل كده عم فاروق. حاول تجيب lateral flexion. So that's forward lumbar flexion, and then we have the lateral flexion. أعمل كده عم فاروق. Very minimal movement as well. So there is a flexion of the lumbar mobility as well. Okay, عم فاروق. تعال اقعد هنا. تعال هنا. تعبينك معنا عم فاروق. Okay. Of course, we have to see the chest expansion as well, because as we said, the costovertebral. So we come at the level of T4 and we do خد نفس وطلع. أيوة. There is limitation of the chest expansion as well, which it should be more than 5 centimeters. Here it's very much limited as well. Okay, so we have cervical affection, thoracic affection, and as well we have specific tests where we see the sacroiliac joint. The first test that we have is what we call the distraction test. So, معلش عم فاروق. So we look at the anterior, we locate the anterior superior. All these tests for the sacroiliac joint are what we call provocative tests. We elicit pain in the sacroiliac joint. So we have the anterior superior iliac spine here, and we distract as much as possible. So that's very painful to the patient. This is called the distraction test. Also, we've got Ginsland's test. This test, معلش عم فاروق عايزك تيجي على حرف السرير. We get our patient as much as possible to the edge of the bed. We let the one foot drop down completely, and he hugs the other as much as he can. And of course, by me Pressing here and stabilizing this elicits pain to our patient. So this is a Gensler's test, which is positive. We also have the Patrick's test or the Farber test, another provocative test where we do the figure of 4. We stabilize the sacroiliac joint and I press over the elbow. Again, it elicits pain. So this is the Gensler's test as well. One final test that we do to test for the lumbar, we just need 2 provocative tests for the sacroiliac joint. Do not forget, of course, and this was shown to you in the ASCII, to do Schober's test. Schober's test assesses the degree of forward lumbar flexion. We have to take, of course, the Schober's test. Modified Schober's test is we locate the posterior superior iliac spines here with a pen. We take the midpoint and we go 10 centimeters up. Okay, with another pen for the sake of time. I haven't got a pen here. Okay, so we need 10 centimeters up. Okay, and then we take another 5 centimeters down, and then we let him bend forward. This should increase. Of course, here it increases by less than 1, so it is limited lumbar flexion. So the first test for the sacroiliac joint was the Gensler's test. The second test was the Farber test, okay, or the Patrick's test. Okay, and this is shown in detail to you. عم فاروق عايزك تنام تاني. So, collecting the sacroiliac provocative tests, we have got 2 important provocative tests. We've got the Gensler's test, which we get the patient onto the edge of the bed, and we press here. This elicits pain in the joint. That's the Gensler's test. Then we also have the Farber test, which is known as the Patrick's test. Farber stands for flexion, abduction, and rotation. And we press on the knee joint, it elicits pain. That's the Farber test. We also have the distraction test that I told you about. Pressure over the anterior superior spine. And we also have the lateric pelvic compression, where we compress over the sacroiliac joint, and that also elicits pain in the sacroiliac joint. Okay? Right. Don't forget, in the general examination, we have to always examine the heart for aortitis. We have to examine the blood pressure. We also have to examine the chest, because there may be restrictive lung disease, there may be interstitial fibrosis, and we always have to examine the abdomen as well. Okay, Farouk. Enthesitis, if it occurs, it will be in the heel here of the foot as well. Shukran, Farouk. Okay, so just to review what we did with our patient, the most important thing, if we are confronted with a patient of low back pain, is to take the history. Is it inflammatory or not? Is it associated with morning stiffness? The duration of morning stiffness? The peripheral arthritis should be asked about, the chest pain, the heel pain, and the extra-articular manifestations. So these are the points that we analyze when we have a patient with chronic low back pain. Onset, duration, radiation, aggravating, relieving factors, nocturnal pain, and also the morning stiffness. And do not forget that you need at least 4 out of the 5 criteria for you to diagnose inflammatory chronic low back pain. And this table very nicely depicts these differences, and of course you should all know it very well. This is just to indicate the peripheral arthritis. Our patient had complaints of knee, but he has not have any active arthritis. It can be active. Enthesitis is, as I showed you, over the heel, and it's quite evident here on the right hand side. These are the criteria that you will be given in the lecture, these criteria we use to pick up our patients. But as you see, they are all based on chronic back pain lasting more than 3 months and the age of onset less than 45. And then we put our patients either sacroiliitis on imaging or HLA, and that's given in the lecture. We also have the modified New York criteria, which we will be explaining in the lectures. So this is the classical clinical picture. Male in the 40s, as you see, with a pain lasting more than 3 months, and these are the musculoskeletal features that we should examine: sacroiliitis, spondylitis, enthesopathy, asymmetrical arthritis, and tenosynovitis. Extra-articular, always to ask about, is the uveitis, conjunctivitis, psoriasis, inflammatory bowel disease, cardiovascular involvement, pulmonary involvement, not to forget the genitourinary involvement and the renal impairment. So that's the classical picture: chest pain, heel pain, knee pain, peripheral arthritis. Extraskeletal manifestations should always be asked about. Eye manifestations are very important, and this is what we did. We always inspect, we look at the patient, we observe the patient's stance, we feel for the tenderness, and then we let the patient move. So inspection of the gait is very important. We observe the cycle, the symmetry, the turning of the patient, and we note for any signs of discomfort. Also, we examine from the back, as I said. Palpation is very important. It picks up the spinal alignment, tenderness, the muscle spasm. Special tests that we did. From the front, always note the head and the neck posture as we did, and the symmetry of the shoulders. Inspection from the side picks up the curvatures and the spinal deformities. From behind, the head posture, the shoulders, the scapulae, the scars, the sacral dimple, and the muscle wasting. Palpation is very important, as we said, when you palpate along and for the alignment and the irregularities and the tenderness. Cervical spines, we should know the normal range of motion. Our patient had almost no range of motion, but we should all know that cervical extension, the normal range is from 0 to 50. Also, the extension, the flexion is from 0 to 80. Rotation, as we said, looking to your right and to your left, and the lateral flexion, taking the ear to the shoulder. At the occipital wall test that we spoke about, and the measurement is always very important, as we said. The lumbar spines are also very important. Forward flexion, finger to floor. Lumbar extension is also important. If you don't want to do cervical expansion, you can do thoracic rotation to the right and to the left, and the modified Schober's test that we assessed, and you will be taking in your OSCE as well with Dr. Iman. The test for the lumbar, we've got, as we said, the Schober and the modified Schober's test, and the classical way of doing it. 10 centimeters, you mark a point halfway between the two posterior superior iliac spines. You take a point 10 centimeters above and 5 centimeters below. The patient does maximal flexion. It should increase up to 20. Our patient was almost 1 or less even than 1. Sacroiliac joint, we just elicit tenderness and pain, localized tenderness, lateral pelvic, and the two important tests that you know are the Ginsler's test and the Faber test, which is the flexion, abduction, external rotation, or the Patrick's test. And if the pain is anterior, it's hip joint. If the pain is posterior, it's sacroiliac joint. That's how to differentiate if the pain is due to the hip joint affection or due to the sacroiliac. That's for the tenderness that we check over the sacral dimples. This is what we do not want to reach. A review of your tests. Lab tests are important. HLA-B27 is important. It's not important in diagnosis, but we can find it in 95% of our patients. ESR and CRP may be positive. Blood tests are normal, but sometimes we can find a mild anemia due to chronic illness. Pulmonary function tests will show affection if there is a thoracic involvement with a diminished vital capacity. X-rays are very important. You will be taking all the details in the X-rays in the radiology department. The early signs that we pick up is erosion, pseudo-widening, sclerosis, and of course at the end, syndesmophytes. Now we pick it up very early with MRI or CT. This is a classical picture of a patient having ankylosing spondylitis with complete obliteration, as you see, of the sacroiliac joints. Here, complete obliteration and affection of the joints as well. Lateral spine, again, squaring of your vertebra, sclerosis and osteoporosis. Aims of treatment, no cure to date, but we're doing much better. You have to keep your patient on a non-pharmacological approach as well as a pharmacological approach. Control pain as much as we can. The cornerstone of therapy is non-steroidal anti-inflammatory drugs. Maintain the patient mobile and prevent any deformities as much as you can. The drug of choice, non-steroidal, is of course the simplest and the cheapest, which is endomethacin. Disease-modifying drugs we don't use in the axial, we just give it in the peripheral. We can give sulfasalazine and methotrexate only in peripheral arthritis, in ankylosing spondylitis. Never give steroids except under very specific conditions, very specific flares, and now we have our new therapies, our biological therapies, TNF blockers, and of course interleukin-17 inhibitors. I thank you very much for your attention, and I wish you good luck in your career.